Thank you very much, Dan. I think Dan has stolen a little bit of my thunder because he's really, in explaining to you where the spherical aberration originates from, he's obviously shown you the hint as to where the solutions arise. So that's what I'm going to run through with you. I'm going to show you through 4 different examples of ways of dealing with this elevated spherical aberration. Remember that some spherical aberration in the cornea is good. We want there to be spherical aberration. And if you want to know why, you can come to the presbyopia talk that I'm doing tomorrow on Presbeyond or laser blended vision, where we use spherical aberration to increase depth of field of the cornea, which is of benefit for presbyopia. So the issue here is controlling the amount of spherical aberration, or in this case now, reducing it if it's excessively high. So the first approach I'm going to show you is a transepithelial PTK. Dan was alluding to this a few minutes ago, that when you do a myopic ablation, of course you're removing tissue from the center of the cornea, but you actually get expansion of the stromal fibers in the periphery. So the effective optical zone is often reduced as a result. And if you were to simulate using, for example, here an Artemis epithelial scan and remove consecutively epithelium from the surface further down deeper into the cornea, what you'll notice is, for example, in this 50 micron ablation pattern, you start to selectively, in white, remove stromal tissue from the periphery. The epithelium, which is thickened after the myopic ablation in the center, acts as a mask, so you don't remove stroma in that area. So effectively, just doing a transepithelial PTK down to a controlled level, you can start to remove tissue in the periphery, which, as you can see from the illustration below, results in a reduction in your spherical aberration. And approximately 23 microns of stromal ablation in the periphery would be equivalent to about a 0.5 micron decrease in Z4 in the form of a wavefront-guided treatment. But you've also got to be wary, because obviously the deeper you go, the more you will remove in the periphery, but eventually you'll reach the base of your original myopic ablation, and it's of no more value. Here you're just using up excess stromal tissue. The idea of this approach is that when you have very, very low reserves of central tissue, it can be beneficial to preserve central tissue. But as I said, it is limited to the amount of which the epithelium can mask the ablation in the center. You can repeat it several times, but eventually you will reach a maximum of benefit in this type of approach. The second method that you can do... Yeah,
can I make a point? Go back 2 slides. Because this is if you want to try this at home.
Can we go back 2 slides? Oh, sorry.
If you look at the simulation of what will happen as you're going down, here what we would do is we would stop at 60 microns. The reason being that we don't want to go between 60 and 65, because now we're starting to get a lenticular cut in the center of the cornea. What we're trying to do is remove only the bumps in the periphery, represented here in the horizontal extraction from the 55 map. So you're basically transepithelially going down to remove the bumps, the expansion, but not take more than that out. Otherwise, it's a hyperopic ablation, and the patient ends up myopic. So the key, if you want to try this at home, without any Artemis or anything, OCTs, is that you try and do a 60 micron ablation. And that's it. Just don't touch. Just do the 60. You'll see a donut of breakthrough in the periphery. Put the bandage contact lens and come back another day and see whether the complaints have gone. And you can actually, as Glenn said, repeat that.
Yeah, Tim is going to, in his section of the talks, he's going to show you what to do if you don't have this Artemis mapping to guide you. And also, intraoperatively, the epithelium and the stroma are very easy to tell apart. The epithelium still remains very shiny, and the stroma has a much more matte appearance. So you can start to gauge exactly where you are just by the appearance intraoperatively. Okay, another method, of course, we know hyperopic ablations. They will, in the nature of the way that they work, induce a negative shift in spherical aberration as part of the treatment. I'm just going to show you a case where occasionally this may be of good advantage. This is a patient with moderate myopia, some SIL. The pre-op spherical aberration was reasonable, 0.3, and post-operatively, what we tried to do for this patient was, in fact, a blended vision approach, a presbeyond treatment. And we wanted the spherical aberration to sit at what we would call a good threshold, or a tolerable level, with less than 0.56 microns. So what we found is, in fact, this patient overcorrected. The distance eye in this case was the right eye, it was at +1. The reading eye, instead of -150 target, was around about planar. So we also noted that the spherical aberration was slightly elevated. And simply by doing a normal hyperopic ablation correction, we were able to obviously bring the refraction to the desired level, but at the same time bring the amount of spherical aberration into a more acceptable level. Remember, we want there to be spherical aberration present, particularly for this type of treatment, for presbyopic correction, because it increases the depth of field in the cornea, which is beneficial to the patient's tolerance. Dan spoke a little bit now about wavefront-guided ablations. We know that these have been around since 2000. There are many laser platforms out there now. Most of them have a wavefront-guided option. And what we did is sample the literature, teasing out some of the big clinical studies relating to all these different types of lasers in very different centers. And when we looked at the effectiveness of these wavefront-guided approaches, what we found is that if we averaged them out, there was an improvement in pretty much all of them, but the average was about a 32% improvement, and that includes a little extra one which got a 60% improvement in the middle, you can see over here, which kind of does skew the results a little bit. But it, as Dan pointed out, didn't flatten the wavefront. These people still had some spherical aberration left within their visual systems. What it did do is bring them down to, in the patient's view, a subjective improvement level of spherical aberration. So their night vision improved to a reasonable, tolerable level. The question is again, what is this threshold? Where is the spherical aberration level going to be well accepted by the patient and beneficial, and where is it going to be significantly elevated to a level where it's actually detrimental? So this is a study performed by Dan a few years ago, where he looked at a repair group. These are patients complaining of night vision disturbances post-LASIK, 16 eyes in the study, and they all underwent a wavefront-guided repair. He compared these to a control group. These are patients who underwent a modern aspheric ablation for myopia, and after surgery were not complaining of any night vision issues. And he matched them 4-to-1 and compared the pre- and post-operative aberration profiles. And what he found was really interesting. If you look at the wavefront-guided repair group, obviously, before surgery, these patients had significant amounts of spherical aberration, and they were complaining of night vision problems. Post-operatively, through doing a wavefront-guided repair, they were able to reduce the amount of spherical aberration, not completely flatten it, but just reduce it. And when we compare that to the control group, where, of course, we all know when we do surgery, we induce some spherical aberration, we noted that while there was an increase in spherical aberration, those patients were still quite happy. So if we look across now at the contrast side of things, if you look at the control group, while their spherical aberration increased as we expected to, these people still enjoyed very good contrast and good night vision. There was no detrimental effect on their vision from that elevation of spherical aberration. In the wavefront-guided repair group, we achieved a 27% reduction, but this significantly had a normalization effect on the contrast. So in the process, improved their quality of night vision. So it seems from these two groups that we can then determine that the amount of spherical aberration that is tolerated pretty well by patients seems to sit around 0.56 microns in a 6 millimeter zone. The problem with wavefront, or one of the issues with wavefront, and we'll see there's two issues with wavefront as we go along, but one of the big things is that it's quite tissue hungry. And it's tissue hungry in comparison to what I'll talk about next, which is the topography-guided patterns. This is just an example of a patient who underwent 2 wavefront-guided repairs. Unfortunately, what the patient was sent to us for an opinion, but the previous treating surgeons had failed to recognize that, in fact, this patient has super thick flap at the original surgery. And by simply trying to correct some aberrations there that actually brought the RST down to 150 microns. So we have to consider that wavefront corrections are a little bit more tissue hungry as a mechanism of how they go about repairing the aberrations. And if we compare a single case, this is a case with high spherical aberration, and we look at the wavefront-guided versus the topography-guided simulations of repair, you see that the central tissue removal in the topography-guided is significantly less than the wavefront-guided, and even at the maximum point there is a difference. So topography-guided treatments seem to be more tissue-sparing to be able to achieve an improvement compared with wavefront-guided. But there's a little bit more to the story than that, and we're going to talk a little bit more about topography-guided treatments now. This is an example of zone enlargement, of course, in trying to optimize your spherical aberration. One of the best ways to do it is just to simply enlarge your optical zone. And you can see the pre to post significant enlargements in these myopic patients. Looking more specifically, and again, this is a study done by Dan a few years ago, where he compared wavefront to topography. What you noted is that there is a decrease in the wavefront-guided ablation group in terms of the amount of spherical aberration, but if you can compare that to the topography-guided group, there was a substantially more beneficial effect using the topography-guided ablation when compared with the wavefront, 17% versus 42% reduction. And this is isolating the spherical aberration. Of course, even if you consider that there was a large decrease, if you look at what the control group, this is going back to the original control group, ended up at, in many instances, the amount of benefit brought these patients to even a lower level compared to the aspheric profiles that we're using today. And the same applies to hyperopia. This is a case of a patient who had PRK for a large hyperopic ablation in 1994. I'm pleased to say I wasn't doing laser surgery in those days, but that looks a bit scary to me. PRK for +5.5. But if you have a look, the optical zone was really, really small. When the patient presented to us, the refraction was +750 with a -175 SIL. And a really, really tiny optical zone. If you look at the Artemis there, you'll see it's only 5 millimeters from the thickest point of the epithelium across the cornea in those two areas. So what we did is we targeted a +6 hyperopic ablation in this patient. We actually targeted the patient to +150, but at the same time applied the topography algorithms, and we managed to proceed to enlarge the zone, and we're able to get it out to an 8 millimeter optical zone, which substantially improved the patient's quality of vision. Incidentally, we got a little bit more out of the ablation than we anticipated refractively, but the optical zone was hugely enlarged. And this is just another example, again, with a very small zone hyperopic ablation, which has been extensively enlarged using topography-guided treatments, and yet another example over here as well. So spherical aberration, high levels of spherical aberration can be resolved in several methods, and it's really down to the clinician to work out how much tissue reserves you have and which tools you have at your disposal. Each one will benefit in slightly different ways in this regard. So I'm going to actually hand over now to Marine Gauvet, who's going to talk a little bit more about decentrations and management of those.
And any questions in the meantime? Okay, we'll only take a couple, but yeah.
You mentioned that the population had more improvements with the aberration in the wavefront-guided.
Yeah.
But isn't this going to be a two-stage correction, because you're first going to...
No. Okay, so the question is, topography-guided, we have said, removes less tissue than wavefront-guided. The question is, but isn't it going to be two-stage anyway, the topography-guided followed by refractive, and then the sum total is the same as if you'd just done a wavefront? I think that's your question. With the Zeiss system, the refractive accuracy of the topography-guided treatments is unbelievably high. We really don't expect to need to do enhancements more than 5 or 10% of the time with the Zeiss topography-guided system, with the MEL80. So the answer is no, it's not going to be more tissue because of the enhancement, and I believe that wavefront-guided enhancements are equally unlikely to reach target with the machine that you're probably thinking about, because they don't have internal algorithms that measure the influence of the higher orders on the refraction of the patient. And that really is the key inside the Tosca from Carl Zeiss, is that they've managed to calibrate, not perfectly, because there are some areas where it deviates, but I can mention in a second, but they've managed to calculate the influence, for example, of secondary astigmatism on what you will have refracted the patient with primary astigmatism. And so it doesn't correct the primary astigmatism that is accounted for by secondary astigmatism in the topography, for example. And so the refractive accuracy of the Tosca is much, much higher. The thing I was going to mention was, for example, where this doesn't work as well is in Hyperopic Wavefront-guided. And that's probably because the epithelium thickens so much more in hyperopic corrections than in myopic corrections, that the error of the topography is higher, error versus actual stromal surface, which is something we're going to cover later. Okay.
So I presume that the machine not only takes the aberration of the cornea, but also the refraction of the patient.
Yeah, of course. You plug in the patient's refraction and the topography, and it calculates what's the best thing to do. Yeah, that's correct. So over to Madame Gobet. Sorry.
I was going to add that also in the hyperopic wavefront-guided repairs, you still focus on the middle of the pupil, whereas they tend to have large angle capitals. So topography-guided decenter your ablation to the visual axis is going to give you a much more beneficial effect in controlling the aberrations compared to the wavefront-guided treatments inherently, unless they have a very, very small angle capital.
Yeah, well, that's exactly what Marlene is now going to talk to us about. And as I mentioned, she's an optometrist, PhD optometrist, so respect on the optical side. Okay. All right.